Hello, my name is Brent Reed, and I'm an assistant professor at the University of Maryland School of Pharmacy and a member of the Atrium Cardiology Collaborative. Today I'll be covering the concept of cardiac preload, which is part of our series on advanced heart failure. Now recall the determinants of cardiac output are heart rate and stroke volume. And stroke volume can be further divided into its three determinants: preload, cardiac contractility, and afterload. Today we'll be focusing specifically on preload. Now, preload refers to the amount of cardiac stretch that occurs during diastole, when the chambers of heart fill with blood. The impact of preload on the force of contraction is analogous to a rubber band. That is, the more stretch, the greater the force of contraction. Similarly, the more volumetric pressure in the ventricles at the end of diastole, the greater the force of contraction during systole. Therefore, the primary determinant of preload is left ventricular end diastolic volume, which can be estimated clinically as the left ventricular end diastolic pressure, or LVEDP. In a patient with heart failure, we can determine if a patient has excess LVEDP based on signs and symptoms of volume overload, but we'll come back to that in a few moments. Now, there are often times when a patient's volume status is unclear, and determining the LVEDP can help us decide which therapeutic strategy is best. Now, LVEDP is difficult to obtain directly, but it can be estimated by obtaining the pulmonary capillary wedge pressure. The wedge pressure can be measured by inserting a pulmonary artery catheter, also known as a Swan-Ganz catheter, through the right side of the heart where it can be wedged into a branch of the pulmonary artery. Now, because the cardiovascular system is a closed system, in the absence of mitral valve disease or pulmonary arterial hypertension, the wedge pressure should be approximately equal to the LVEDP. Now, the relationship between preload and cardiac output is described by the Frankstarling mechanism, which can be depicted by the following curve. Here, the x-axis is LVEDP, or wedge pressure, and the y-axis is the stroke volume, or cardiac output. Now, as you can see, as preload increases, so does stroke volume, and thus cardiac output. Now, like a rubber band that's been stretched too thin, this relationship only works to a point. In heart failure, the Frankstarling curve is smaller and flatter, reflecting a reduced cardiac performance. Now, excess preload in patients with heart failure does not produce improvements in cardiac output, but it can lead to the signs and symptoms of volume overload, such as shortness of breath or lower extremity edema. Now, since excess preload is due to excess volume or pressure from the venous system, signs and symptoms of volume overload can be improved by reducing volume, which is commonly accomplished by the use of diuretic therapy. Volume overload may also be improved by increasing the capacitance of the venous system with the use of venodilators like nitroglycerin. Now, in general, improvements in volume overload in patients with heart failure do not change cardiac output because of the flatness of their Frankstarling curve. However, it is thought that patients who are extremely volume overloaded may actually fall off the Frankstarling curve, where excess volume confers a decrease in cardiac output. Here, removal of excess volume is thought to get patients back on the curve, thus restoring the relationships between preload and cardiac output illustrated here. Now, cardiac function in patients with heart failure is rarely returned to normal, but it can be partially restored by optimizing medication therapies like ACE inhibitors and beta blockers, or the use of vasodilators or inotropes in patients with acute decompensated heart failure. Now, in very rare cases, preload can actually be too low in patients with heart failure, which can also be detrimental. And this most commonly occurs when patients are over-diuresed. In this kind of case, cardiac output may be restored with gentle fluid administration, but again, caution must be exerted in patients with heart failure, as even gentle hydration can produce symptoms of volume overload. Thank you, and that concludes our presentation on cardiac preload.